I'm Jeff Betcher. I've been asked to speak about the role of GeneXpert in antimicrobial stewardship. It's really all about the quicker administration of the narrowing of antimicrobial therapy, and I'll get into the reason why that's important in a minute, but I have to do the sort of preliminary kind of things, the disclosures. This is part of the clinical quality improvement program with the Health Quality Council that I'm involved with. So this is part of my project, but that's not why it's being done, actually. And a lot of the credit goes to the team that's supporting this project. And Jessica Minion actually really got this up and running, and she just graciously allowed me to run with it while I do the program. My sponsor is Dr. McCutcheon, my coach is Dr. Sweetheart, and the people that are really doing all the work, aside from, as well as Dr. Minion, are Michelle Dagelman, Bob Parker, Jason Vanstone, Casey Phillips, and Jonathan Mailman as QI and pharmacy support. But what it's really all about is how quickly we narrow our antimicrobial coverage for bloodstream infections. Specifically, in this case, it's gram-positive cocci in the blood, and the mortality rate. This is the U.S. statistics. I can never find Canadian statistics. I don't know. I guess we don't keep them or something. But anyway, the American ones are always quoted. And in 2002, it was thought to be responsible for over 30,000 deaths in the U.S. With a mortality rate of 34 to 52%. And in the first decade of the 21st century, it increased by 17%. And in 2009, it was thought that 1 in 23 hospitalized patients had bloodstream infections. So anybody that's in clinical practice knows that as soon as you suspect a bloodstream infection, that you want to get on it, and you want to get on it fast, and you want to get on it right away. So our knee-jerk response is always to cover the most likely things that we think they are. And as an intensivist, that really means that I put people on triple antibiotics, including vancomycin, something like Pictats, and something to cover gram-negatives like ciprofloxacin. But it's really just one organism that we're usually treating. And in this particular case, for this particular test, it's Staph aureus that we're treating, that we're targeting, or that we're identifying. But it's a significant mortality, as I had alluded to earlier, but also associated with Staph aureus is significant morbidity in the way of by way of infective endocarditis. We often see a lot of people that have infective endocarditis in our population, in the medical ICU at least, and also the risk of metastatic infections, septic emboli to the brain or other parts of the body are very significant. And that's why we're so aggressive to start early antibiotics. And the question is which ones? And because we don't have an identified organism, we just broadly cover them with everything. But there's also important implications to that as well. And it's not great stewardship. That's why we're doing antimicrobial stewardship rounds. But the other thing is that we've seen over the last number of years the emergence of resistant organisms because of the broad spectrum antibiotics that we use and the sort of very way that we use antibiotics generously, although we do tail it back when we can. So we've got things like vancomycin-resistant enterococcus that we're dealing with as a complication of using vancomycin. We also have the emergence of MRSA in the last few decades that has also been a problem, hence the move to vancomycin and the emergence of VRE. So there's those issues. But another issue is the toxic effects of the antibiotics themselves as well. Vancomycin has a significant nephrotoxicity associated with it. And if you look closely, many of the patients, at least the patients that I look after in ICU, probably do suffer a certain degree of nephrotoxicity from the vancomycin. So getting them off the vancomycin, if possible, is what we're interested in doing. And the risk of nephrotoxicity then is made higher as we add antibiotics, as we have more complex patients. There's sort of multifactorial things which further complicate that risk of nephrotoxicity. So what this particular test wants to do, or does, is it changes, or it allows us to more quickly identify, or the lab rather, I don't do the work, the lab does all the work, they should get all the credit for it, but it allows the lab to identify in a quicker fashion for us, specifically with this test, the gram-positive cocci, and to identify specifically what those are. So if you consider traditionally how we get blood culture results, this graphic here, I think, illustrates it pretty well. We get blood cultures drawn at time 0 at the left on the bottom. And if you go towards 24 hours, we start to see the results of our gram stain of the blood culture. Many clinicians, though, when they get a positive gram stain, won't change their antibiotics yet until they know for sure whether, if we get it coming back with a gram-positive cocci, it doesn't help us to really identify, is it MRSA or is it a methicillin sensitive, and can we narrow the spectrum of our antibiotic? So most of us don't really change our antibiotics until we get the identification and the susceptibility. And if you go over to the right upper, that doesn't happen until about 66 hours, or at least 66 hours. And I think it's sometimes at the bedside closer to 3 days by the time all of that gets through. So, and if you look at, as part of what I had done, we took, I think there's 12 patients here, and we looked at what was the time between time 0, or the administration of the first dose of antibiotics, and the time when the final therapy was instituted prior to this GeneXpert test that I'm going to talk about in a minute. And the sort of the mean and the median, the red and the blue lines, are around the 60-hour mark. And some of them are as high as over 120 hours, almost approaching 140 hours before the antibiotic spectrum is narrowed. So we've got a sort of prolonged period where we're exposing our patients to a broad spectrum of antibiotics, which is the best we can do, but not ideal. And how can we make it more ideal? There is another investigation or test that can be done, and I think the lab has the ability to do it. It's called MALDI, which stands for Matrix-Assisted Laser Resorption Ionization. Oh, it's a mouthful. Don't ask me what it is. It's a laser, and I think they have fun with the laser. I think Dr. Minion said they can do really cool stuff with the laser. I think it uses mass spectrometry, and it can detect the particle sizes and whatnot, which is specific to the organism, right? Yeah. But that takes, according to this graph that Dr. Minion has produced, it's around the 44 hours mark before you can identify that. And so we're still looking at 40 hours of broad spectrum antibiotic coverage. And again, we're looking at, before we get identification and susceptibility, 66 hours. So can we do better than that? And this is just another look at MALDI. I guess you can get faster gram-negative identification than gram-positive. But again, it's just showing the results there. The test that has recently started to be used in Regina is something called GeneXpert, or the proper name for it I had in my title, actually. GeneXpert is the proprietary name. But what it uses nuclear amplification technology, or PCR technology. And it allows actually for the identification of gram-positive cocci and the susceptibility around the same time as it takes to get a gram stain. So now we've moved from 66 hours using the traditional, more conventional methods that have been used to 24 hours or less, to be able to identify whether we have what we have and how we can better treat with the narrower coverage with our antibiotics. So this platform, what it does, it directly identifies Staphylococcus aureus and the MECA resistance genes in blood cultures. This is just for blood cultures for this particular test. And it uses the nucleic acid amplification testing. And in some of the literature that I was looking at, there's a paper from the Journal of Clinical Microbiology in 2012 from a group in Australia using the second generation of this product. They found that their sensitivity was 100% and their specificity was 96.7%. And in their case for their paper, they took the invalid results were considered to be false positives. One of the questions when I was talking to at least the intensivists about this particular test was, well, what's the sensitivity and specificity? Because if you can't have a sensitive and specific test, you're just not going to trust it. But based on this and certainly the information that I've gotten, it is a reliable test, and it will allow us to narrow. And the report comes out as one of three results. It either tells you that it's positive for Staph aureus and positive for MECA, which is the MRSA, which is the gene that renders Staph aureus resistant to methicillin. So if you get a positive Staph aureus and a positive MECA, then you've got MRSA. If you could mute your mics remotely there. The second result you can get is positive for Staph aureus and negative for the MECA.
I'm sorry to interrupt. It's just Balcaris. We've lost our videos feed for you. We're looking at eHealth Saskatchewan homepage. So I don't know if there's anybody that can help us with that.
There's some IT here, so hopefully you can fix it. So you can get the two positive results for Staph aureus, and it will identify whether it's MRSA or whether it's methicillin sensitive, or you get simply negative for Staph aureus. And if it is a positive blood culture, the likeliest thing that would be then would be a coagulase negative staph, which is usually a skin organism that's contaminating the culture. So the next question that always comes is, how much does this cost? Because anytime you want to do something new, those that hold the purse strings want to know, what is that going to do for our budgets? I do believe that to acquire a laser to do MALDI is about $250,000, something like that. The lab already has one, so that's not an acquisition cost for that part of it. I don't know about the rest of it. But certainly to implement this, in 2016, the equipment costs there were no equipment costs because I think the equipment's already in place. The quality control, proficiency testing, and the development and training of the lab, about just just above $1,200 a year. And the supplies is the biggest cost per year, based on their estimates, would be about $32,000 for a total per year cost of $33,320,000. Which, if you think about the cost of, I don't have the breakdown of, but if you think of the cost of what it would be to isolate patients because they have MRSA or they're thought to have MRSA and not proven to have it, because often if you get a gram-positive culture and you think they might be MRSA, they get isolated. So there's a cost of that. There's a cost of cleaning the rooms. There's the cost of extra antibiotics for the extra couple of days. There's the cost of the complications of the antibiotics. If you have renal toxicity, if you're exposing them to broad-spectrum antibiotics and you get an emergence of a new VRE from it, and you have to isolate them as well, I think that's probably well recouped with this and narrowing that. And that's about all I have to say at this point. So this was instituted in April, mid-April. And so for those of you that are working in Regina, you may have noticed the change in the way the reports come out, and you can act on those reports, and you can narrow your spectrum of your antibiotics sooner based on those reports. The second part is that we will be collecting data just to see the effect of bringing this test in. Has it actually changed our prescribing practice in the region? I have spoken to the Department of Medicine, the Department of Surgery. I believe I sent a note as well to the Department of Family Medicine, and to the Emerge as well. So everybody's, and if I've missed anybody, I apologize, and this is my way to try to make sure it gets out there some more. And I think it was also put in the physician's newsletter. And yeah, so we'll see. Stay tuned. We are tracking to see how, if this is going to have a good effect. And that's really about all I have to say, except for questions.
Are the antimicrobial reports, do they have that it was the GeneXpert that tested it, kind of like the Molly-Top does?
I think they do, yeah. Oh, the question was whether the reports, when they come out, if they identify it as using the GeneXpert test, and yeah, they do.
And there's no restriction for peds or NEO?
There is no restriction for peds or NEO. It's all blood cultures. Okay. Any questions from the sites that are teleconferencing in or WebExing in? Oh yeah, if you are trying to talk, *6 to unmute. I've either won everybody over, or they're all skeptics and they're just going to go keep on doing their thing.
Do they have this test? Is it just in Regina, or is it like the Yorkton Hospital have access to it? Or?
As far as I know, the question was, is it just in Regina? As far as I know, it's just in Regina right now. Okay. Thank you very much.